Look into this question. 2-year-old child passing continuous dribbling of urine and also passing good volume of urine, diagnosed with bilateral ectopic ureter. Next step in the management of this patient. What is the next step? Option A, ureterostomy. Simple. Option B, simple reimplantation of both the ureters. Option C, reimplantation of single ureter in the bladder. Option D, reimplantation of single ureter into the sigmoid. So, whenever there is an ectopic, the right answer is option C, reimplantation of a single ureter in the bladder. See, try to understand, when this is the kidney and this is the urinary bladder, right? Now, if there are two ureters, the proximal ureter will open distally. The distal ureter will open proximally. The ureter which drains the lower portion of the kidney will drain proximally, and or double ureter, both can join together, can have a common orifice. You should understand the upper pole ureter or upper moiety ureter, which drains the upper pole of the, predominantly the upper pole of the kidney, which opens distally, is mostly ectopic. And in case of women, it will open distal to the sphincter urethrae. So, female patient will become incontinent. Okay. So, the question very clearly says, diagnosed with bilateral ectopic ureter. When you say bilateral ectopic ureter, so it can be anywhere other than the normal position of its opening, either in the bladder or outside the bladder. But in the question, when you see, there is a good volume of urine. That means when there is a good volume of urine, one ureter, though it is ectopic, it is an ectopic location in the bladder. Instead of the trigonal area, it opens somewhere else, proximally or distally, anywhere. And the other ureter, which is ectopic, that is causing dribbling of the urine, that opens distal to sphincter urethrae. So, that is the reason why there is a dribbling and also a good volume of urine. Understood? So, that means the ureter that opens into the bladder, you need not do anything. Just leave it alone. The ureter which does not open into the bladder, which causes continuous dribbling of the urine, has to be reimplanted. Is it okay? So, that is the answer. I have very clearly explained. Though it is ectopic, one is clearly opening into the urinary bladder, the other is opening outside of the urinary bladder, distal to the sphincter urethra. That is the reason why the dribbling of urine is there. So, that ureter which is ectopic in location, which opens distal to sphincter urethra outside the bladder, only has to be corrected and to be reimplanted. So, the answer is option C. Is it okay? Okay, let us go through what is given in Bayesian law. Ectopic ureters are almost always associated with the ureteric duplication, 10% are bilateral. Okay. There is a female or male ratio of 7:1 and is indicated above. The ectopic ureter drains the upper pole of the kidney, inserts the bladder more distally than the normal and towards the bladder neck. Okay, that we have seen. In female, ectopic ureter opens into the urethra below the sphincter or into the vagina. So, that is the reason why there is a continuous dribbling. A female who voids normally but who has dribbled urine. See that? A female who voids normally. See the statement in the question also. One voiding is also normal, but who has dribbled urine, as long as she can remember, is a typical of patients with ectopic ureter. In male, the opening of the ureter is above the external urethral sphincter, so the patient is continent. Okay. Ectopic ureteric orifice in male at the apex of the trigone. So, ectopic ureteric orifice can be in the apex of the trigone also, or in the posterior urethra, or in the seminal vesicle, or in the ejaculatory duct. Okay. And it is likely to be functionally abnormal and infection is common. That means, in male, it will not be below the sphincter urethra. That is the reason why all the statements are given. Seminal vesicle, ejaculatory duct, posterior urethra, or just above the sphincter urethra. All the structures. Okay. Now, read this. Page number 1401, Bailey and Lau, 27th edition, very clearly says, a severely diseased or atrophic moiety is effectively treated by a partial nephrectomy. So, that has been spoiled because of this arrangement, that can be treated by partial nephrectomy because it could be infected. A reflexing ureter may need reimplanting. Okay, because it is not opening normally, that ureter could have a vesicoureteric reflex. That is the reason why that moiety could have undergone a reflux disease and could have got complications, and because of that, a partial lymphadenectomy is indicated. An ectopic ureter in female often drains hydronephrotic and chronically infected anal tissue and is best excised. Rarely, incontinence can be cured and renal function preserved by re-implanting the ureter into the bladder. So that means the very idea of this question is, see this, the ureter that drains normally into the, not normally into the bladder, an ectopic position in the bladder, voids a good volume of urine, you just leave it. That, the other ureter which goes outside the bladder, which drains distal to the sphincter urethra causing dribbling, that alone you reimplant. The reason why reimplantation of single ureter in the bladder. Is it okay? So in this question, there is no signs and symptoms of hydronephrosis, no signs and symptoms of infective focus. So that means the other ureter which drains, or both the ureters that drains the kidney, drains completely without a reflex. There is 2 ectopic ureter only. There is 2 ectopic ureter. There is, it's given already in the question. Then why are you asking that question? 2 ectopic, but 1 ectopic is in the bladder, other is outside of the bladder. That's it. Both the ectopic outside of the bladder cannot have a good volume of urine. Both will have dribbling of urine. Understood? Your question, answering to your question, if both the ectopic ureters are outside of the draining outside of the bladder, both will have only dribbling. They will not be a good volume of urine. TEG, thromboelastography, indicates what? Platelet function, viscoelastic property of the blood, extrinsic pathway, intrinsic pathway. When I got the question, there is no option E. I have ordered option E actually. I mean, you need to check whether this question and options are right. Where all these were there in the question, if you can recollect. On that day, on the same day I recollected, this was the option given to me by the students. If all the options were given and all the options are right, all the options are right. Yes, all are correct. I don't know how to comment on this question, but all are correct. If something in the question, if would have been there, that could, particular aspect is asked in the question, probably that could make a difference in this answer, or else it indicates A, B, C, D. Out of, indicates everything. If you ask me one option of among this, I will tell option B, because you asked that question. Okay? Because you asked this question, I am giving it to you. Is it okay? No, see, it tells you about what kind of coagulation profile the given patient has and what kind of behavior it has. Understood? So, for that, all these parameters are important. All these parameters collectively give that graft. See this. Whatever the shape of the graft that you are able to see in TEG, all the parameters are important and required. Understood? So, this image you would have seen in Bailey and Love, and this we have discussed in the regular classes also, and also in revision classes. So, it is very, very evident that all the options and components are important. Okay, child puke score. For a patient with albumin 2.2, INR 1, moderate ascites, well-oriented, bilirubin 2.3, what is the score? See, when you look into the score, bilirubin is more than 3, 2 to 3, less than 2. Albumin more than 3.5, 2.8 to 3.5, less than 2.8. INR less than 1.7, 1.7 to 2.2, more than 2.2, encephalopathy, uncontrolled, uncontrolled, ascites, uncontrolled, uncontrolled, right? Now, when you say albumin 2.2, that means the score of 2. INR 1, the score of 1. Moderate ascites, score of 2. Well-oriented, score of 1. Bilirubin 2.3 is score of 3. Now, add this. How much you get? When you add all this, how much you get? See, moderate ascites is only 2. Severe ascites is 3. Correct? So, it is to be only 2, right? What is albumin given? Once again. Albumin 2.2. Yeah, there is albumin 2.2. Yeah, albumin 2.2 will be 3. I'm sorry. Bilirubin 2.2 will be overall, it will not change. It is 2. Still the score, I think, will remain the same. So, child's A 5 to 6 points, B 7 to 9 points, C 10 to 15 points. So, this comes under child's B. 2-year-old child planned for a surgery for a midline neck swelling adjacent to the hyoid bone with a chalky yellow liquid. What is the management? So, this is a clear-cut question of all of you. This is a clear-cut question of thyroglossal fistula. So, thyroglossal fistula or a cyst, the treatment of choice is always cyst trunk operation. So, it has to be excised. The tract has to be excised from foramen cecum. Correct? From foramen cecum with the body of hyoid bone, then body of hyoid bone up to the isthmus. So, the entire tract has to be excised. This is called cyst trunk operation, correct? Cyst trunk operation. So, Schwartz 11th edition, page number 1710. Okay, page number 1710. So, it is very clear the resection of cyst in continuity with the central portion of the hyoid bone and tract connecting the pharynx in addition to the ligament at the foramen cecum is curative in 90% of patients. Okay. So, if the duct retains the connection with the pharynx, infection may occur, resulting in abscess, necessitate incision and drainage, resulting in a salivary fistula. Okay. So, that is the reason why you do this surgery. Okay. A patient had a gastric cancer with tumor infiltration to subserosa with 6 positive lymph nodes. What is the stage? Straightforward question. And I think there should not be any difficulty with this respect to this question. Okay, if it is a moderate ascites, then what is severe ascites? Is it 4, is it? Subiston 21st edition, for a severe ascites, what is it given? So, it is no ascites, mild and moderate, am I right? Is that what it means? Yes? No, mild, moderate, correct? Okay. So, in that situation, you make the score 10. Finished. Chapter closed. Yes, you follow Subiston more than Schwartz. Finished. Is it okay? So, you know the parameters, accordingly you will calculate the components. Done? Okay. So, what is the answer here? Okay, the right answer is 3A. And it is a simple, straightforward question. And T4B, N1, M0, T4A, N1, M0, T4A, N2, M0, T3, N2, M0, T2, N3A, M0. Under 3A, which category it falls? Can you identify the status? Subserosa and 6 positive lymph nodes, no distant metastasis. Am I right? That's what is given in the question, right? Yeah. Now you tell me. And I have very, very clearly told you. It is nothing of you just seeing the recorded videos. You need to interact with the faculty, talk to me or any other faculty for rest of the specialities. You need to interact and learn. And you should never learn a pre-recorded video without any interaction. You should have a touch on daily basis with the subject. Okay, right. T3, N2, M0. Is it okay? Very clear? So, it is T3, N2, M0. Schwartz 11th edition, page number 1145. It is given in any other book also. Same stuff. Most common cause of chylothorax in children. Almost. But you will always follow AJCC 8th edition. Okay. So, there is a multiple answer, divided answer. Option A, birth trauma. B, thoracic duct atresia. Option C, filariasis, post-surgery. So, the right answer is post-surgery. Subiston 21st edition, page number 1840. Chylous pleural effusion, usually secondary to thoracic duct trauma. Usually iatrogenic after chest surgery. Rarely a manifestation of advanced malignant disease with the lymphatic metastasis. Presence of chylomicrons or lipoprotein analysis at triglyceride level more than 110 milligram per deciliter in the pleural fluid or diagnostic. So it is a thoracic duct trauma. That is the most common cause. Is it acceptable or not acceptable? If it is not acceptable, let me know. Thoracotomy surgery in children. There are multiple causes. There are very many causes. Thoracic causes are very many. Yes, they are the same. PDA closure, how is it done? One of the common surgeries. It's a PDA closure. Previously, a thoracotomy was done. Today, it is VAT assisted. VAT assisted clipping of PDA. Previously, it was an open surgery. Yes. There are so many lung causes and so many cardiac causes which entitles for a thoracotomy. Understood? Or a chest surgery. Okay. False statement regarding abdominal wall reconstruction. Negative pressure wound therapy to reduce wound necrosis. Quilting stitches prevents wound seroma. Perforator are abandoned and 3 cm from umbilicus, around 3 cm from umbilicus. Drain placed to reduce seroma. What do you think as an answer is? So the right answer for this is negative pressure wound therapy reduces the granulation tissue, increases the vascularity and regeneration, granular regeneration, healthy regeneration. But it does not reduce the necrosis. The causes of necrosis could be multiple. Causes of wound necrosis could be multiple. Whatever the necrotic material, negative pressure wound therapy clears off. Understood? So, let us go through the explanation. High risk complication observed in diabetic, 21st edition of Subiston and page number 1933. Very clearly says, the high risk complications are observed in diabetic patients with BMI greater than 30 kg per meter square. The most frequent minor complication are surgical site infection, seroma, hematoma, and wound adhesions. Progressive tension sutures continue to gain support to reduce the incidence of seroma. Smokers are at high risk of infectious complication, major complication including necrosis of the abdominal flap, deep venous thrombosis, pulmonary embolism, or more frequent when surgery is combined with intra-abdominal and gynecological procedures. Routine chemoprophylaxis is not indicated in patients with low risk. The use of intermittent pneumatic compression devices, has shown to be superior than elastic compression stockings. This is for DVT. So look at the options. Among the options given here, the best answer I believe is option A. Shall we move on to the next? Urine dribbling through umbilicus is because of what? Patent vitreointestinal duct or urachal fistula? Which one will be the right answer? So urachal remnant or urachal fistula could be the appropriate answer here. Option B. And 11th edition of Schwartz also says 1145. In child presenting with the draining of umbilicus. We will see all the questions. A diagnosis of patent urachus is considered. Yes. So I think this is more than enough. 35-year-old man met with a road traffic accident, came to the ER. Continuous watery nasal discharge. Treatment. Quilting stitches reduces the dead space. That's what I believe to reduce the seroma. So predominantly all your answers or antibiotic and observe. The answer is wait and watch. See, the antibiotic has to be given only started when there is indication for a infective etiology or infective focus, and causes of meningitis or ventriculitis, something has to be there to start an antibiotic, or else you have to wait and watch. Prophylactic antibiotic and usage of antibiotic can lead to antibiotic resistance, and when it is getting really infected, then you may not have an appropriate antibiotic to treat this patient. That's the whole idea. So, wait and watch was a definite answer. I think the definite option was there, and somebody is saying the X-ray was also one of the option. Negative pressure wound therapy can be used in necrotic wound. It can be used in necrotic wound, that is fine. correct? But I have heard on the same day, most of them saying that it reduces wound necrosis. It is used in necrotic wound to clear the necrotic debris, but it does not reduce the necrosis of the wound. That's my point I'm trying to tell you. Hope you understand what I'm trying to tell you. If there is an evidence of meningoencephalitis, then you should start antibiotic, or else you should not. That's what evidence says. X-ray was an option. Probably you can add, instead of some options, X-ray you can take it up. X-ray you can take it up, but that may not change the answer also. Here the answer which the question is asked is treatment. When the treatment is asked, X-ray is only for diagnostic. Okay. Now I will go through the explanation given in Schwartz 11th edition, page number 219. Most common scenario, which at times may be life-threatening, is bleeding from the facial fracture, and temporizing measures include nasal packing, Foley catheter tamponade for the posterior nasal bleed, and nasopharyngeal packing. Prompt angioembolization will halt the exsanguination of hemorrhage, exsanguinating hemorrhage. Fractures of the tooth-bearing bone or considered open fractures require antibiotic therapy. So, open fractures, indications for requiring antibiotic therapy: open fractures, fractures of the tooth-bearing bone, yes, and require antibiotic therapy, and semi-urgent repair to preserve airway as well as functional integrity of the occlusion, bite, and the aesthetics of the face. Okay, the orbital fractures may compromise vision, produce muscle injury causing diplopia, or change orbital volume to produce a sunken appearance to the orbit. Nose and nasoethmoidal fracture. Nose and nasoethmoidal fractures should be assessed carefully to identify damage to the lacrimal drainage system or to the cribriform plate producing cerebrospinal fluid or CSF rhinorrhea. After initial stabilization, a systematic physical examination of head and neck should be performed, and also includes cranial nerve examination, 3-dimensional CT scanning of the maxillofacial complex. Okay. So, watery discharge very clearly says is a CSF leak. Okay. And the CSF leak best settles without doing anything. And the best will be wait and watch. An antibiotic is indicated only if there is an associated open fracture, yes, and is there any indication of any source of infection. This patient has just landed up in ER. The best option is to wait and watch. See, antibiotic and observe will give you a comfortable answer for your mind and the heart, but that is not the exact answer. The antibiotic has a specific indication in case of CSF rhinorrhea, and you can go further research in the rest of all the books also. Then when you come to the next class, you will definitely agree with me. If these were the options. Shall we move on? See, I'll tell you, these options are almost same, correct? You tell me what is the difference between option B and option C? There is no difference. Yes? There is no difference. And why are they asking such questions? Yes, this is a trap. This is a trap. Examiner wants you to answer antibiotic and observe. Do you understand? Giving antibiotic and waiting and watching, in what way is different from antibiotic and observation? See? Whether you will use antibiotic or not. That is the question all about here. Yes? All these are related only. Nasal packing is also related here. Immediate surgery is also related. You can do nasal packing also, no? That is not mentioned in the question, no? Rohit, you are right. But what is given in the question only I can take. I cannot imagine things. Yeah. If meningitis comes, then you give antibiotic. You give an antibiotic, and if meningitis comes, if you exhaust a potential antibiotic, there is a higher risk of losing the patient. You understand? Because this is a clean wound. As of now, this is a clean wound. Then why should you have a classification of wound? Correct? Clean wound, clean, contaminated. Yes? Yes, in a clean wound, will you give an antibiotic? You will not, right? So this is a clean wound. Why do you want to give an antibiotic? Okay? So do not jump out of evidence. Do you understand? Another 3-4 classes. Another 3-4 classes we will definitely set in. All our frequencies will get aligned. Yes, and one thing I'll tell you, I will always practice what is given in the book, not my experience. I'm telling you very clearly. Yes, all my old students know. Yes, and you will also learn what is evidence, what is given in the book. Only that will be taught here. All filtered. High level of filters. I don't put my experience as an opinion here. And if I have to tell my experience, I will tell this is an experience of mine. Nothing to do with the question. Okay? Okay. 2-year-old child with a left abdominal mass and pain reduced after passing large amount of urine. Diagnosis. Doing NEET SS 2022 recall is very, very important. And I'll be doing one more session now. So this question can be even in the app also, it can be visible to everyone. You just make an option. Question visible to everyone. 2-year-old child. So what is the answer here? The right answer is Ureterocele. This is a trap again. Again, this is a trap. Why? Now, we are coming to an important aspect of discussion here. Now, minimum 20 questions in general surgery were from pediatric surgery. And those 20 questions of pediatric surgery are from the book of Holcomb and Ashcraft. Though the similar related topic are there in Subiston and Bailey and Schwartz. But there are certain questions which has direct references and line by line from Ashcraft. This really made me a little uncomfortable for the reason that the National Board of Examination informing the post MS and DNB students that 150 question a new pattern of exam of a PG exit standard. I am repeating this. NB says 150 question of a new pattern of a PG level exit standard. I am really worried and afraid that saying such statement and giving questions from pediatric surgery, a super specialty book, in general surgery 40 marks, will give a leverage for the exam setters tomorrow to ask of the 150 questions, out of 150 questions, at least 50 to 60 or 75 questions from the specialty books. I am worried on that. Because nobody can say, what is PG exit standard, correct? There is no limit that the PG, even in a PG entrance examination, they ask at the super specialty level. There is no limit. Nobody can say, this is a PG question, exit question, this is an SS question. Nobody can say. So, the students who gave the exam also told me, sir, there are certain questions in pediatric surgery, they are easy to answer with general surgery knowledge. So, there are certain questions which are all little high above the PG standards, which we found really difficult. So, in other way, National Board has taken too much of leverage and space that anything, that means initially it was only one specialty or two specialty students were preparing. Either gastro or uro or gastro or surgical onco, and another 40 question was from general surgery. So, it was all predefined. Now, making 150 from all subspecialties of general surgery and making us to assume that to be in only from Bailey, Subiston and Schwartz, and student goes in depth of preparation on of all these three books. But if the question is asked like this, like what we are going to discuss for another 10 to 15 questions out of this, you will be able to experience that. That why can't it happen to rest of other specialty books also to read. That means NB is slowly converting that a single specialty to be a multi-specialty learning. I don't know. Only by next exam of 2022, it's happening in July or June or July, we will know after looking into the question, how they are asking. Is it only of a PG exit standard or more than that? We mail, all this comes next. First you see the question. First you see the question and the explanation. Then you will understand what we should react to this. But some mistake has happened. By mistake they have given this pediatric surgery into this. General surgery in the last exam. So, Ashcraft's Pediatric Surgery 7th edition, page number 848. It says, most ureteroceles are identified prenatally, although 10 to 15% still present postnatally due to infection. The obstructed renal unit may be palpable, but most have no clinically apparent abnormality. Bladder outlet obstruction is rare because most ureterocele decompresses during micturition. See that? But the most common cause of urethral obstruction in girls is prolapse of ureterocele. Now you can ask me a question, sir. Can a PUG obstruction produce a Little's crisis? Yes, it can produce a Little crisis. But when there is a ureterocele is an option there. When a ureterocele is an option there, ureterocele will score more than PUG obstruction. Yes, ureterocele will score more than PUG obstruction because it is more spontaneous than PUG obstruction. Understand that? Understood? So what happens? So it's very, very clear that, so it's a bilateral condition. So the urine gets accumulated in the cystic dilatation around the ureter in the intramural portion of the ureter in the bladder. So what happens is the kidney gets dilated, it becomes palpable, and there is a superadded infection or complication. If it's a stretch of the capsule, then there should be a pain. Even pain can be there in PUG obstruction also, renal calculus also, and vesicular reflex. All this can have pain. So pain cannot be taken as a factor here. But pain reduced after passing large amount of urine, it can happen in renal calculus if it is getting lodged into the ureter and then gets lodged into the bladder and comes out. Even it can happen in renal calculus. Even in a PUG obstruction, it can happen. Vesico-ureteric reflex can also, it can happen. But all the four are close options to cause such kind of symptoms. But among the four, the more spontaneous is ureterocele because it can happen in every act. Once the act of micturition happens, this cystic dilatation gets decompressed and automatically the urine will flow out. Is it okay? It is not the mass, it is the hydronephrosis. Yes, it's a hydronephrosis. The most common cause of abdominal mass in children is what? What is the most common cause of abdominal mass in children? This is the question to you. It's not a Wilms tumor. It is hydronephrosis. It is hydroureteronephrosis. If you want an answer as neuroblastoma, the most common cause of malignant abdominal mass in children, understand this. The most common cause of malignant abdominal mass in children is neuroblastoma. If you want an answer as Wilms tumor, it should be the most common cause of asymptomatic malignant abdominal mass in children. Correct. Multidysplastic cystic kidney comes under second to hydronephrosis. Most common abdominal mass in children, number one cause is hydroureteronephrosis. Number two is cystic dysplastic kidney. Hydronephrosis of any cause. Hydroureteronephrosis of any cause. See, it's very, very fine line. It's a precise learning. It has to be very, very precise. I mean, calculus, renal calculus can cause hydronephrosis, slips into the ureter. Ureterocele can cause hydronephrosis. PUG obstruction causes hydronephrosis. Vesico-ureteric reflex also can cause hydronephrosis in this question. And all can cause spontaneous passage of large amount of urine. Among that, the most common is ureterocele. You should understand that. I am not saying this will not, all will cause, but among the cause, given cause, in 2-year-old child that too. This is the best. This is the best. Yes, ureterocele will be bilateral. Why not? That is the reason why there is a large amount of passage of urine. You understand? There is a reason why large amount. More appropriate for this question. Ureterocele is always bilateral. More commonly seen in female. Only kidney will be palpable. What else you want it to be palpable? See, I will tell you, it can be palpable, it may not be palpable. See, you read the option here. Here in the question, it is palpable given, accepted. Accepted. Yes. Read this. Obstructed renal unit may be palpable, but most have no clinically apparent abnormality. Okay? And most of the ureterocele will get automatically decompressed during micturition. So, left side here, it is because the ureterocele probably could be more significant on the left side. That's the reason why left kidney probably might have been palpable. The percentage between PUJ and ureterocele, I will refer and tell you in next class. What is the percentage of ureterocele which is more common? Next class we will discuss. For this question, my first preference will be ureterocele. Among the four, all the four are capable of causing. So, congenital diaphragmatic hernia is due to deficiency of. Hopefully, you remember this question. Yes, this question was asked. Some might have had, some may not have had. Answer is vitamin A. Again, from Ashcraft. Vitamin A, see, we'll see, although exact etiology of CDH is unknown, these teratogens commonly affect the retinoic acid synthesis pathway by inhibiting the retinol dehydrogenase 2, causing similar diaphragmatic defects. Several clinical observation and molecular studies have supported the importance of retinoic acid pathways in congenital diaphragmatic hernia development. Vitamin A deficient rodents, see that vitamin A deficient rodents will produce offsprings of congenital diaphragmatic hernia, CDH of variable severity. So, retinoic acid receptor knockout mice produce features of CDH. Failure to convert retinoic acid to retinaldehyde following administration of nitrogen produces posterolateral diaphragmatic defects in rats. Lower plasma levels of retinoic acid and retinol binding protein in infants with CDH have been found compared with controls. So, it is the 7th edition of Ashcraft's, page number 380. Is it okay? Acceptable? Very clear? Shall we move on? 2-year-old child, history of lymph tumor after 6 months, child presented with recurrence. Okay? After chemotherapy, what can be the histology? If you are made right, it's good. If you are made wrong, you will learn. That's it. But your response are very important. Diffuse anaplastic is the right answer. So, again in Ashcraft very clearly says, tumor designated as diffuse anaplastic must have at least one of the following 4 criteria. What? Anaplastic cell outside the kidney, presence of anaplasia in random kidney biopsy, anaplasia in more than one region of the kidney, anaplasia in one region with extreme nuclear pleomorphism in another site. Anaplasia occurs primarily in children older than 2 years. Okay. And Wilms tumor, NWTS1, has 66.7% of patients with anaplasia experienced relapse and 58.3% died of the tumor. Also, there was a high frequency of relapse and death in diffuse subgroup. Is it okay? Infantile hypertrophic pulmonary stenosis, mucosa is breached. What is the next step? Mucosa repair and intact myotomy. So, all of you answer this option A, right? Okay? But the right answer is option B. So, you should know what Ashcraft says. Page number 482. Holcomb Ashcraft, Pediatric Surgery Book, 7th edition, 482 says, the operation should be converted to open, number 1, if you are doing laparoscopically. If the perforation is large or in the middle of the myotomy, then the myotomy should be closed with the absorbable suture. Okay? So, you have You have punctured the mucosa. Okay? Then if you have punctured the mucosa, you have to see if the perforation is large and it is in the middle of the myotomy. Then see, you will make so you make a longitudinal incision. Whether it is large or there in the middle of the myotomy, right? A new myotomy can then be made 90 to 180 degree from the original incision. Repairing this injury is difficult to perform laparoscopically, so conversion is usually necessary. Feeding should be held 24 hours, then restarted. A water-soluble contrast study can be performed but desired. So, I will just read this once again. If the perforation is large or in the middle of the myotomy, then the myotomy should be closed with absorbable suture. A new myotomy can then be made at 90 to 180 degree from the original incision. So, usually we were taught, once you make a perforation in the mucosa, suture the mucosa and nil per oral for 48 hours, IV fluid and observe, correct? That's what we have been taught, that's how we have been, the concept is with us. But you read the book, the evidence in Ashcraft says, if you have made a puncture and it is significant, yes, or is there in the middle of the myotomy, then you have to do one more myotomy. Is it clear? Mucosa is breached. If the perforation is small, they would have given small perforation, correct? We cannot assume and presume things. If the perforation is very small, you can leave it like that. Very minute, insignificant, then could have better to leave it only, no? Like how do you do in esophagus? So, is this answer acceptable, not acceptable? So, every question and answer was, this is a very clear cut standard of a superficiality. This is not a general surgery question. So, you can't take it to the face value. Okay? Or else, I have searched I have to search for the options also. Just not for one line in Subiston or Schwartz or Bailey will suffice. Would have been there, I would have quoted that evidence. 2-year-old child with sternal torticollis treatment. So, the right answer is wait up to 5 years. Again, Ashcraft very clearly says, page number 1182, 7th edition, that is the recent edition as of now. Some surgeons advise delaying operative intervention until the patient is at least 5 years of age, as studies have shown better long-term outcomes due to improved compliance with physical therapy and collar therapy in older children. See, try to understand all the superficiality question, all the 4 options will be right. Which among the 4 you need to choose? Yeah, it's physiotherapy only. But here, how long physiotherapy was not given, no? How long physiotherapy has to be done is not there. So, there is not a very specific 100% answer. How long you need to wait is very important. All will be tricky only. And I will tell you one thing, until you migrate from MS, post-MS to DNB to superficiality, only then you will be, that maturity will help you to understand this. See, the decision is very important. See, once you decide to wait for 5 years, then you will do physiotherapy. It is not that other way around. By giving physiotherapy up to 5 years, it is not getting treated, again you will go for a next line of management. Is it okay? Do you understand that? So, all these are aspects of supportive treatment and treatment of torticollis. Any further questions by anyone? Some surgeons advise delaying operative intervention until the patient is at least 5 years of age, studies have shown better long-term outcomes due to improved compliance with physiotherapy and cholotherapy in older children. So the answer is to wait for 5 years. During the waiting period, you do physiotherapy. Okay? Because physiotherapy is a support that you give in the waiting period. Because it is not spontaneous. Which of the following is not used for an IV access in a neonate? So this is in children, is it? Was the question in children? Because when I wrote on the same day, it was neonate which I have marked, which I have mentioned, which I have noted down. Was it a neonate or in the children? It was a neonate. I was remembering like a neonate when question was delivered to me. Okay, let us read the reference. So proximal saphenous vein is being an answer here. The location of the distal long saphenous vein anterior to the middle malleolus is fairly constant and frequently palpable and making it one of the most popular veins for the IV access. Okay, peripheral IV access, particularly in infants, because this reference was taken for infants. Page number 134, again Ashcraft's. It allows a larger catheter and excellent stabilization of the catheter as well. Scalp veins can be readily visible and accessible, but it can be difficult to maintain the access for a length of time. Similarly, external jugular vein catheter tend to get dislodged promptly in a moving patient. So may be useful only for a short time. And IJV we use commonly. External jugular, if it is there in the option, IJV is also we use commonly. Okay, so scalp vein, EJV, IJV are used. Which is asked not used is proximal saphenous vein. Scalp vein is used. After P sharp, anal dilatation will begin. So the right answer is 2 weeks. And again Ashcraft gives in page number 594, anal dilatation can be started 2 weeks after the repair. Once the desired size is reached, colostomy can be closed and anal sutures develop when the blood supply to the distal rectum is insufficient. Anal strictures develop when the blood supply to the distal rectum is insufficient or when the anoplasty was performed is under tension. Okay. Routine daily dilatation may not be required in all patients. Regular checking by the surgeon to ensure that a stricture is not developing in a potential alternative approach. Okay. Most common organism causing cervical lymph node abscess in children. The answer is Staphylococcus and Streptococcus. I was amazed to see the word to word. Amazed to see the word to word. The most common cause of acute cervical lymphadenopathy is a bacterial infection arising from the oropharynx or elsewhere in the drainage area. The most common organism is a penicillin resistant Staphylococcus and Streptococcus pyogenes. Yes? Now you believe that this are directly taken from these books? Yes? I have gone through all the other 3 books also. This is not there. Exactly the same words, same architecture, look and feel, the paragraph converted into an MCQ. Very clear. Okay, girl with dysmenorrhea diagnosis. I think they have mixed up the paper. There's some mistake has happened. Some mistake has happened. 100% has happened. The right answer is option A, imperforate hymen with dilated introitious. Again from Ashcraft. And primary amenorrhea with cyclical pain was there in the question. Okay, fine. Okay, let us go through that. Now, imperforate hymen, an isolated anomaly arising from the failure of canalization of urogenital sinus is most commonly diagnosed. Obstructive anomaly incidence is 1 in 200. Symptoms are typically first noted during puberty with, see that, cyclical pelvic pain. This is what you are typing, no? See that? Cyclical pelvic pain. Yes? So it is there. Associated with the absence of menstruation, distension of the hymen with the bluish discoloration. Yes? With the continued accumulation of menstrual blood, pelvic mass or obstructed genitourinary or gastrointestinal symptoms may develop. Occasionally newborns, okay, present with the mucus accumulation, abdominal mass, transabdominal ultrasound reveals dilated vaginal and uterine canal. It is, if this is found during the childhood and is asymptomatic, correction is usually deferred until the onset of puberty, and surgical excision of the hymen with the evacuation of the retained menstrual fluid provides the permanent relief. Okay. So, is it all acceptable? Primary amenorrhea. Primary amenorrhea with cyclical pain. Correct? This I am adding now. Dilated introitious was not there. Okay, I'll just put it in the bracket if it is not there. Rest of all is okay. Dilated vagina was there in the question. Very good question. So I have made in the question. It will be saved. Less than 1 year old child, asymptomatic with meant to be mutation of exon 9 on 8. What is the management? Total thyroidectomy in 3 to 5 years. Immediate total thyroidectomy with neck dissection. Observed till puberty. Annual screening with ultrasound neck. 3 to 5 years was not there in the option. This was not there in the option. Question, ultrasound neck done, normal and thyroglobulin normal. It was there. So, ultrasound neck done. Normal and TGB normal. Correct? Normal calcitonin was also there. Okay. Okay. Very good. ND was not an option. Huh? What is ND? Neck dissection. Huh? Neck dissection was there or not there? Was there in the question or not there in the question? Was there. Okay. So now what is your final? So now we have made up some into the question. Now you tell me one single answer, all of you. What is one single answer that all of you want to give after adding all this? Okay. Predominantly you have gone for option B. Less than 1 year old child. Right. Answer is B. Very good question. And Ashcraft very clearly says RET gene mutation. Normal physical examination, normal ultrasound neck, measure serum levels of calcitonin and CEA. Okay? Very clear? And children, adult. When you look into children, this is the question on that. See that meant to be, if it is meant to be, meant to A, okay, and it is ATAH and ATA MOD. Okay. Now, if it is meant to be total thyroidectomy, see that? Total thyroidectomy in the first year or first months of life based on the discussion with the endocrinologist, the surgeon, and the parents, level 6 lymph node dissection, okay, dependent on the ability to identify and preserve or transplant parathyroid has to be done. So, this question is meant to be. Selva Kumar says even proximal vein is also used in infants. But even among the options of external jugular, internal jugular and scalp vein, still the proximal saphenous vein would be a better answer there. Among the options, comparatively. Because Ashcraft says distal. So, Ashcraft is a bigger book than Schwartz. So, meant to A, total thyroidectomy at or before 5 years of age based on the serum calcitonin levels. And next, when you see ATA MOD, meant to A, total thyroidectomy to be performed when serum calcitonin level becomes elevated or in childhood if the parents do not wish to embark on the lengthy period of evaluation which might last for years or decades. Very clear. Answer is you should do immediately because the child is already in first year. Shall we move on to next? So Bailey gives, but this classification is not there in Bailey. This clear-cut indication is not there. Each and every line by line in Bailey is there in the app. We have discussed. Line by line, Bailey based, Bailey table based, Schwartz, Subiston also. All important lines, tables, everything discussed. Children with a congenital inguinal hernia, the age of repair. See, yesterday I was discussing this question. You remember? And what we discussed yesterday? We discussed as 18 months. You remember? Yes? The same question in Ashcraft says, do it immediately. See that? The presence of inguinal hernia is an indication for an elective repair. It is not necessary to restrict an asymptomatic child's activities preoperatively. The prompt repair may decrease incarceration, particularly very young. So, candidate study found that children under 1 year of age had twice the risk of incarceration when repair was performed more than 2 weeks after diagnosis. Okay. So, we have to change the answer to once diagnosed. Is it okay? Because it is an authority. So, it is an authority. Okay, 4-year-old boy had complaints of deformed phallus, had 5-alpha reductase deficiency. What is the next step? Counsel the parent for sex conversion to a girl, local application of dihydrotestosterone cream till phallus develops, followed by reconstruction, wait till puberty, refer to a plastic surgeon. What will be the appropriate answer that you want to give? So, the right answer is wait till puberty. Wait till puberty. The Nelson textbook of pediatrics, 21st edition, yes, very clearly says the phenotype most commonly associated with this condition results in males who have a small phallus, bifid scrotum, urogenital sinus with a perineal hypospadiasis and a bifid vaginal pouch. Testes are in the inguinal canal and labioscrotal folds are normal histologically. There is no Mullerian structure, Wolffian structure. The vast difference, epididymis and seminal vesicles are present. Most affected patients have been identified initially as females. At puberty, virilization occurs, phallus enlarges, testis descends and grow normally, and spermatogenesis occurs. And there is no gynecomastia. In infants with this condition should be treated as males whenever practical. Treatment of male infants with dihydrotestosterone results in phallic enlargement. Okay. If we have an option here, local application of dihydrotestosterone till phallus develops, followed by reconstruction. This statement is not correct. This is a complete statement. So, you need to wait till puberty, and most of the cases, the phallus will enlarge, become normal. Okay. So, this is not a must that you need to do a reconstruction in all cases, because option B says that. So, no mention of 5-alpha reductase enzyme. Okay, fine. But the most appropriate answer here will be wait till puberty. Reconstruction is not required in all cases. Then how we can take B as an option? We cannot take, right? And after puberty, if it becomes normal, then why do you want to do a reconstruction? Of course, we agree dihydrotestosterone treatment is mentioned. But the second part of the option makes it not correct. Okay. Patient had a tetany corrected with calcium, normal Chaustuck sign. What is the cause? Hypomagnesemia. Magnesium deficiency must be considered in patients with unexplained hypocalcemia. Everyone knows that. So, I think that we may not go into the details. Level 4 evidence is case series, case report, randomized control, cohort. This is a repeat question. This is a PG level repeat question. This is exactly PG standard. All of you, answer please. It's a case series. Level 4 is a case series. Okay. So this will be available for you in the app. You kindly go through that. Most common worm in the CBD. What is the most common worm in the CBD? Correct. It is Ascariasis. So it is given straightforward. It is in, we are back to Bailey, 27th edition. The brown pigment stones are associated with the presence of foreign bodies within the bile duct, such as with this endoprocessus stents or parasite chronic sinuses or Ascariasis lumbricoides. Okay. Most common cancer in Meckel's diverticulum is. Okay. The right answer for this question should be carcinoid. Again, we are going back to the pediatric surgery Ashcraft, 7th edition, page number 641. Meckel's diverticulum found incarcerated in a hernia which may be located in the inguinal, femoral or umbilical or spigelian sites. In adults, especially in elderly, neoplasia can develop within the Meckel's diverticulum. Carcinoid is the most common tumor. But other malignancies include adenocarcinoma, leiomyosarcoma, gastrointestinal stromal tumors, lymphoma. Neonatal presentation of a Meckel's diverticulum is uncommon and typically is due to perforation or obstruction. Now you tell me, is carcinoid the answer or adenocarcinoma the answer? This book is the authority. This book is the authority. So it is a very clear-cut evidence that minimum 20 questions are from hardcore pediatric surgery. Hardcore pediatric surgery, no doubt about it. Patient with 6 cm rectal prolapse with redundant sigmoid colon, treatment of choice. This is a simple, straightforward question. And all of you can answer this. Yeah, correct. So it's a resection rectopexy. So it is there in all books. So redundant, it is Schwartz 11th edition, page number 1306. Resection of redundant sigmoid colon. In some cases, resection is combined with rectal fixation. Resection rectopexy. Now, before we close, the plan for this year, how are we going to learn NEET SS? The other exam, entry into MCH, is NESS. Correct? Now, you tell me, how many of you are interested only in NEET SS? Just say yes or no for this question. Sir, I am interested only in NEET SS. So, predominantly, it is no. How many of you are interested in only NESS? Next question. Only NESS. Yes, no. NESS. There are people only interested in NESS. Very good. Next question. Both the exams. How many of you are interested in both? Both NEET SS and NESS. Yes, no. Both. Sir, I am willing to prepare for both. Let us take the vote first. So I have not yet to see a no. Both to be prepared, I am yet to see a no. Anybody is going to say no? Is there any candidate? Is no. Who says that? Abhishek. Why Abhishek says no? Okay, I will take. One has said so far. No, one student. One student says no. Rest of all have said yes. See, all done. Sophie says no. Okay, fine. Two of them had said. Sophie will take rank this time. So I will not count Sophie because he will finish this time only. He will go out. Says no. So very less, very few, 1 or 2 or maximum 3 has said no. See, what? Because this has become unpredictable totally. Unpredictable. Only after the exam we will know what will happen. It looks stable. It looks stable. At least for sure, 50 question in specialty of concern specialty will come. Yeah. Now, what are we going to do? That is the next question. How are we going to prepare? What is the plan in speed? Okay. So you have to have both the preparation. That's what predominantly 99% of students want. What is the preparation and how it is going to be there? Now, for NEET SS, proposed 150 questions. There will be two streams of handling. One, Dr. Vinayak Senthil will handle only Bailey, Subiston and Schwartz. Complete. Ekdam. Whatever is available in the book will be given to you, delivered to you. This is part A of learning, and almost 3 days a week we will have a class. Correct? Schedule already I have given you. Now, the other part which I don't want to take a risk, that if the questions like this exam, for example, that pediatric surgery, superficiality level questions were asked. Similarly, out of this 150, even 50 questions of superficiality level is asked, other than these 3 books, then my student will be at a great loss. And I don't want to see that. Okay. Now, what option B will be is specialist from various subsuperficiality, surgical gastro, urology, neurosurgery, oncosurgery, plastic surgery, pediatric surgery, cardiovascular thoracic surgery. So, all the specialist. I am a cardiothoracic surgeon taking general surgery for you. But all the specialists will give a blend of their respective specialty through general surgery. That means they will touch upon general surgery from where I left, from where I am leaving, from hardcore general surgery. They will cover those salient points and take you to the important topics. They will take you to the important areas and topics must cover in specialty. But not full specialty, not to the fullest extent of the specialty. They will not do that. Okay. So, each and every specialty teacher will cover from general surgery up to their respective specialty. The important areas will be, those points will be incorporated. So, you will have blend of general surgery plus specialty in session B. Is it okay? It will not be same as the last crash course. It will be slightly different from the last crash course. Because crash course was involving only the specialist eye on Subiston, Bailey and Schwartz. Here, Subiston, Bailey and Schwartz plus important topics from specialty books. That will be there for NEET SS preparation. Is it clear? This is 2 classes in a week. Now, NESS will be hardcore and advanced specialty learning. This will be 2 days in a week. So, almost 4 days in a week you will have classes by the specialists. 2 days they will be taking general surgery along with their specialty and 2 days exclusively on the specialty. Is it okay? And I will be covering parallelly of only pure hardcore general surgery. Is it okay? So, any extent of question only asked from general surgery, you will be fine. Asked from general surgery plus few aspects of specialty surgery like what asked in this paper, you will be fine. And if you are preparing for NESS, you have mastered this general surgery, 30 questions you can easily crack. Plus what a hardcore specialty which we will be taking, and you will be able to attend 50. So, all done. Okay, this is the plan. And all live classes. Almost 5 to 6 days class in a week, minimum. Only night classes. Only after evening classes. If you miss the classes, you will be able to see the recordings. Okay. Because you cannot see the exam trend is not stabilized. The exam is not stabilized. So, nobody can say, I have a resource, I have a material, you read this and questions will come. How somebody can say that? Nobody can say that. Yes, nobody can say that. As the exams are evolving, as the exams are unstabilized, you need to keep preparing on those perspectives. You need to expect, because you have only 3 to 4 months from now. June is expected exam, right? So, we have to be very clear on what we are going to do and what you are going to prepare. So, this is what is my plan and this is what has been informed to the faculties. Anything that your feedback is well taken. If you are okay, you say okay. If you are not okay, you can tell me, I can modify accordingly. Because at the end of the day, you are the beneficiaries. Being a post-MCH fellow, I thought this structure might suit for the upcoming exam. And in case you feel, no sir, this is not correct or something you want to add into the feedback, you are most welcome in this forum. Yes? And I'll tell you one more thing. From day one, I'm telling you, it will be only the night. Do not read PG level books, number 1. Do not read PG level books. You have registered for speed learning app. Read only that. Because you will not have time to complete what we do only. And it is more than enough. And this standard will be high enough for you to tackle any kind of exam. That is uncomparable, because I have gone through all the apps in the market and they have done something. I don't want to comment on that, and that may not suit the purpose of the upcoming exams. So, kindly follow this. Follow one system, one material completely. Everybody is taking in that type only. And anything else? Specialty recall will start. Every teacher, every specialty, when they start the class, they will start with the recall only. So, that's how I started with general surgery. Everybody will start that way. See, I will tell you, you just hear the videos, solve the questions. That is more than enough. Don't trouble yourself. We have done everything. It's more than spoon feeding. You just hear, get good earphones, keep it in your ears, just listen to the videos, go through the videos, revise those videos, attend the test which will be given in speed. That will be more than enough. It will be done. So, all the videos are uploaded in will be respected folders. So, respective specialties, you can go through that. Okay then. So, anything more than this, and you will send me in my personal WhatsApp and I'll read through that. Okay. So, thank you very much. You want my number? The number is 98400 44686. Thank you. Good night.